Well, good evening, everyone, and welcome to the American Medical Association's second town hall on the Electronic Health Record Meaningful Use Program. Tonight we're in Boston, Massachusetts at the Massachusetts Medical Society in Waltham. It's a great privilege and a pleasure to be here. I'd like to start, though, by first putting in perspective why we're here tonight, how we got to this point, and a little bit about what we hope to achieve. So the purpose of the meeting, as Dr. Dorkin mentioned, is to hear from you, practicing physicians, about your experience with the federal government's Meaningful Use Program and the electronic health records that you use as a result of that program. This is a chance to lend your voice to help impact the advocacy we've been undertaking with policymakers and others across the country. Now, I'm a practicing emergency physician. I work in the hospital often before I go on these trips and after when I get home. I use a mainstream electronic health record, and I work in a hospital setting. So I know what it's like to use this as a tool, and I've shared my perspectives as an end user of these tools with policymakers in D.C. as your president. I've also shared your stories, and as a result of our first town hall meeting, July 20th in Atlanta, we've had hundreds or more physicians across the country, if not thousands, I've lost track of what the total is, share your either video stories that you videoed at home, and some of those are posted on the website now, or your written stories about your experience with electronic health records and how the Meaningful Use Program impacts your experience with those. So let's remember, what was the purpose of the Meaningful Use Program? It was to spur adoption and meaningful use of electronic health records for the betterment of patient care. The concept would be to have every clinician and every patient have access to the right data at the right time to provide the best possible care for patients. And it's been a success by the measure of adoption. More than 80% of physicians have adopted some form of electronic health record technology. Physicians use these now. And hospital adoption has been that or more. And, doctors sometimes have been portrayed kind of astoundingly to me as somehow regressive. We don't use technology. And I find that staggering. I've seen other people describe doctors as digital omnivores. And I think our assertion would be, unfortunately, while the Meaningful Use Program has been a success in spurring adoption, it has been less successful in spurring the kinds of innovation, the kinds of interoperability, the kind of efficacy that we would want it to have and need it to be the best possible tool to help physicians be more efficient rather than less efficient, to help patients get better coordinated care rather than more fragmented care, and to help us to make sure we actually do have not walled gardens, not new digital silos, but islands and pockets of information that openly communicate with each other and become one large ecosystem, all for the betterment of the patient care we're trying to provide.
I work out of Partners on North Shore in Salem, and we've had LMR. So I'm one of the early adopters. I've been using electronic medical records since 2005. There is no way I want to go back to the dark ages when it was on paper and I couldn't figure out the scribble and mistakes occurred left and right. So there's no question we need an electronic medical record. That goes without saying. I can't conceive of practicing without one. However, after 10 years of LMR, Partners decided they're going to go to a new medical record system rather than trying to upgrade theirs, primarily to fulfill the requirements that we're talking about tonight, okay, and in order to do meaningful use. So they're going to spend something like across the hospitals a couple $100 million in order to make this upgrade. That's a lot of money. Now, in my neck of the woods, we have two competing hospital systems. One of the biggest problems I have is I get patients from both hospital systems, and sometimes they come from Leahy, a competitor, who has a completely different medical record system now, and we have to do the old-fashioned faxing, which is absurd in this day and age.
But I also chair a task force, a small one, for the Mass Medical Society on IT mandates. And we've come up with a couple of principles that we think are important that would help make electronic medical records better for everyone, patients and physicians. There's just four of them. Let me just... The first one is to promote interoperability and separate it from the Meaningful Use Program. Separate it. The second is make sure that interoperability is the responsibility of the vendors and don't penalize the doctors for not having an interoperable system. We think this makes eminent sense. The third one is allow physicians, or make it easy for physicians to use the patient portal that's in most electronic medical records as a surrogate for interoperability, so that the patient has the right to delegate a proxy for anybody they want to access their own portal. We ought to make it very easy for physicians to be delegated with the patient's consent to access all the clinical data. And right now, some clinical data is not in there, but that could be fixed. That would be a lot easier to do than some of these grandiose projects for semantic interoperability. And the final principle is just remove all the negative mandated penalties, where obviously we'd like to be incentivized to do this.
And oftentimes as students, if we get access to the EHRs, we're given a read-only access, or if we're given access to write a note, it's a very restricted note. And we're graduating close to 18,000 medical students each year going off into residencies. And we're going to be expected to know how to do documentation when we start seeing patients. And there's no training EHRs out there that are being widely adopted by medical schools. I'm not aware of any. And so I'm not really being trained on how to do this documentation that complies with meaningful use and other coding standards. Yet a year from now, I'm going to be expected to be doing that when I'm out as an intern. And so you asked what we can do to make EHRs better. I think one of the things, at least from the student perspective, is to have that training environment available for us to learn how to do this.
Doctor, I started having EMRs in 2002. We were excited when meaningful use came along. We thought it was going to be a wonderful way to showcase how great what we were doing was, and we discovered it was the opposite. They asked us to do things we weren't doing that actually impeded patient care rather than helping with patient care. We successfully attested every year for meaningful use since 2011. We attested for meaningful use 2 for 2014 for Medicare. We're audited. The entire process took 19 months, has cost me tens of thousands of dollars, and at the end of that, I got a check for $3,900 in the mail.
My name is Teal Van Dyke, and I am the Integrative Systems Coordinator managing meaningful use for Atkinson Family Practice in Amherst, Mass. I'm also the project coordinator for the Program for Ethics and the Common Good at Hampshire College. So I spend a lot of time thinking about healthcare technology and ways to improve it for the most people. I'm 26 years old, and with immense participation from providers and staff at Atkinson Family Practice, I attested successfully for meaningful use stage 2 in 2014, and even passed that 7-month-long audit that Dr. Atkinson was describing, and I taught myself how to do this every step of the way. So what's the problem? There's a whole generation of people just like me with the service ethic and the technological skills to advance the future of medicine, but I wouldn't wish the process I went through on anyone. If everyone is so burnt out trying to meet expectations that are so disconnected from what vendors are able to provide and the reality of providing good patient care, there's going to be nobody left to lead into the future. And I see this every day. Dr. Atkinson is one of few practitioners left in family medicine in our area, with 2 leaving family medicine just the last month. So the stakes are hugely high.
Yes, I'm Glenn Tucker. I'm a traditional primary care internist, which means I do my own outpatient and inpatient care. I'm also the CMIO of our hospital system, and I chair the Mass Medical Society Committee on Information Technology. One of the things that's happened at my hospital was left over from an old Medicare regulation was that for part of our outpatient operations, we had to have one database, and for the rest, we had to have a separate one. Now, we're using the same EMR, running both of these databases, and we can't get them to talk to each other at all. So when I send someone from my system to a specialist in the other system, I have to fax them papers, and then they fax papers back to me, which we each scan into our respective systems. And then patients look at me and they say, "But doc, aren't you the computer guy?" It seems kind of absurd to me that it's the measure that we need to meet, we can't meet because of the measure. So I think that if we had less of meaningful use, we might actually get more meaningful use.
I've led my organization through all of meaningful use. I've built and designed much of how our EHR works. I'm probably the biggest cheerleader we have for the use of an EHR. 99% of our providers attested successfully to stage 1 meaningful use. But I'm here to admit to you that I personally, despite all that, failed stage 2 last year. And why did I fail stage 2? Because 4.9% of my patients sent me a message. 45% have been signed up for the portal, but as you mentioned before, it's a pass-fail. It's all or none. Now, why did only 4.9% of my patients send me a message, despite the fact that as the biggest cheerleader for the system, I talk to all my patients, I talk to all my staff. My staff are fantastic about getting people to use the portal. Well, I, unlike our previous speaker, have 45% Medicaid patients. I have about 25 to 30% patients who English is not their primary language. And for them, the systems are not up to what they need to be for them to successfully get anything out of using that portal. Our vendor actually is great, and we have a Spanish portal, but my patients don't speak Spanish. They speak Vietnamese, they speak Albanian, they speak Ghanaian, they speak Liberian.
Thanks for letting me speak for a second time. I ran some numbers before I came here on what running an EMR costs my office. So we're family practice, primary care, 2 full-time doctors and 2 full-time PAs. We take care of 4,000 patients. It costs us just to run the EMR $103,641 a year. That's not the cost of the EMR or the computers. That's just our annual cost of all of our different infrastructure, having an IT liaison, having a local IT company, the clearinghouse fees, and maintenance. So that does not include the original purchase. And I bring this up because in our area, we've lost 25 primary care doctors in the past 5 years. We've lost 2 in the past month. It's an epidemic. There's not enough primary care doctors. I get 30 calls a day from frantic patients trying to find a doctor. 3 of the doctors that left in the past year all left because of meaningful use, literally. If you ask them, they will tell you that's why they left primary care. And they need to know this. They need to know that they're chasing out the doctors who are the bread and butter, entry level. We're the ones that keep costs down by keeping people out.
I heard a lot of thoughtful people who have spent a lot of time and effort and money trying to jump through hoops so that they didn't get penalized by a program. And notwithstanding that, I heard some people who jumped through a heck of a lot of hoops and spent a lot of time and money and still got penalized. I don't think this is what, it certainly doesn't sound like what was intended when Congress passed the law. It certainly is not consonant with what we as physicians want to do, which is to advance high-quality patient care, to help patients lead healthier, happier lives, and to make the best use of technology and people to do that. And so,
first of all, thank you all for coming. Everybody here has worked real hard all day, and they came, and you're all spending a fair amount of time tonight, and even the people at home watching this could be doing other things, but they know that this is very important. Ultimately, as one of the recurrent themes that I've heard tonight is ultimately it boils down to a physician sitting in a chair with a patient, listening to them, trying to find out what their concerns and problems are, demonstrating to the patient that they're listening to them, their attention is on the patient, and then using all of the knowledge that we have, augmented by certain aspects of the electronic medical system, such as rapid checking of the medical literature, to try to bring to bear everything that we have in medicine to the benefit of the patient. And clearly, in some ways, in a manner more effective than my father, who practiced cardiology in New Jersey for 40 years. But, I still have visions of him sitting there and looking at the patients in the eye and listening to them. And he said, you've got to listen to the patient. That's what they're there to get it off their chest, tell you what's going on. And if you don't do that, then you're not doing your job. So all of us in this room want to do that. I want to really thank you.